The topic is about optimization of robotics and how we do our practice out here. I'll concentrate mainly not on robotics because you have been seeing, hearing, and interacting about robots throughout from morning. I'll talk about mainly how we have adapted as surgeons. Before I start, this is not a talk about that my robot is the best. I think we have all chosen robots based on our specific interest and choice, which is not the topic of debate here. Why I took to robotic? Mainly I thought I would improve early functions, expect better longevity. This was what I read, this was what I thought, and I believed in this technology. I would reiterate this word, I believe in this technology. I thought I believed in this technology when I actually took the robot. When I started using this, I realized that I actually don't believe this much. And I'll tell you why in the future slides. Okay. What happened when I immediately got the robot? I started looking clumsy. I looked slow. My OT list started to suffer. And I thought at that time, the conventional was not that bad. So the optimization word came automatically. In today's modern time where actually time is money and list actually has to go on and on, volume has to be done, optimization had to come. And how I optimized was to reduce time taken in each case so that I would reduce interval between two cases and of course in the end wanted to reduce and do more number of cases. That's why optimization came to me. So to reduce time in each case, I realized that the robot has to start working even before I start to work. While the anesthesia has been given, the robot is set up. The distances are being measured and the technical team takes over. I operate. This is the right side I'm going to operate. The robot is always kept on the opposite side because I like operating from the same side. So I start my right side, the robot is on the left side, and I take when I go to the left side, the robot comes to the right. While the incision and everything is being done, the distances are being gauged. And the wonderful portability of the system helps me that my technician is actually able to get the robot in position while I make the incisions. The trackers took a lot of time initially. We were actually putting one by one, but I thought this was best demonstrated by Dr. Ashok and Dr. Kale. They worked in unison, and while I put the tibia, the femur is being prepared upstairs. So the time taken reduced. I will not go into the nitty-gritty of where to put the trackers and all because you've seen it all. I'll go ahead. Now the tab came in picture. While I do the nitty-gritties, the co-pilot of mine, my colleague, keeps on, making the implant sizes. He actually does the planning and everything helps me save time. So while I'm executing everything is being done on the tab itself. This one thing I learned by my own experience. The tracking took a lot of time. Triangulation initially took a lot of time, but after I just simply removed my side support, the calibration became much, much more easier. And I think the video is working? No. Okay. Yes. So I started using the saw now to remove the osteophyte. That also cut down my time. I'll go ahead. The femur mapping, it's actually a practice. And avoid your points in air. I think the nitty-gritties have already been seen. We mark as shown in the previous live surgeries itself. The tibial marking, now I start to subluxate the tibia anteriorly so that my tibial sizes became much, much better compared to when I started off with. So my femur sizing now are much, much more accurate than what I was maybe 100, 150 cases before. The soft tissue assessment, Dr. Krishna Kiran showed today this spoon. The spoon used to slip out of my hand, but over a period of time what I did was that I used to keep some mops so that the friction increased stability, and this not split out. And I realized that I could use this better with this little piece of mop out there. And the last of thing, start believing in the system. We are all used to mechanical alignment. Once you start using the system, you'll realize that you'll have to make variations in the implant positioning. That is the most difficult step. In the first initial cases, we were actually spending more and more time in releasing these, medial releases was much more because we wanted to put everything in mechanical alignment. As the confidence in system grew, we realized that we had to actually make implant changes, and the soft tissue releases actually have gone down, and we are actually very happy with size 9 spacers without any release at all now. Bone burring is purely practice. I'll not go into this. I think we are also now using the same. We drill we burr the anterior part of it, the anterior part of femur totally, and then use a saw, and we all actually refine a hybrid sort of system, because when the list is very long, you have to cut down on time without compromising on any sort of accuracy. The tibia, I'll not go into it. It's the same. And while Dr. Rajput had this debate, see, once the trial is done, I actually take the trackers off, and the robot is actually shifted to the other side. While I close and cement, the robot is repositioned again and rebooted. So the conventional took 35 minutes. Conventionally, when I was doing it, when we started, it went to 70, 80, 90 in some cases. Now it again come back to 45 minutes with the petla, cementing skin to skin. I think we're still learning, but we've come far. And then while the second knee has been closed, the robot shifts to the other side, and that's the power of portability, and that's what the biggest advantage of this system in my knowledge. 9 months back when we started, we were at one hospital. Now we offer robotic replacements at these centers, and all with one single robo. The take-home message from here is, if you realize it is not the machine which has adapted, it is the surgical team which has adapted, the doctor which has adapted. The machine learning would be actually the next step in optimization. And the ultimate would be when we would have the freedom to do any band of any knee, irrespective of the robot we have. Thank you, ladies and gentlemen, for your patient listening.